After intellectual developmental disorders, under the neurodevelopmental disorders, we also have the communication disorders. So disorders of communication includes deficits in language, in speech, and in communication. So in assessing these three, culture must be considered, especially for individuals growing in bilingual environments. So under communication disorders, first we have the language disorder. So for its diagnostic criteria, criterion A, persistent difficulties in the acquisition and use of language across modalities due to deficits in comprehension or production that includes the following. First, number 1, reduced vocabulary or word knowledge and use. Second, we have the limited sentence structure or the ability sa pagput ng words and word endings together para maka-form ng sentences based sa rules of grammar and morphology. Third one, impairments in discourse. It refers to the ability ng paggamit ng vocabulary and sa pag-connect ng sentences para ma-explain or ma-describe ang isang topic or series of events or sa isang conversation. So, language learning and use is dependent on both receptive and expressive skills. So, expressive ability, nag-refer siya sa production of vocal, gestural, or verbal signals, while ang receptive ability naman, nag-refer siya sa process ng pag-receive and pag-comprehend ng language messages. So, sa criterion A, the child's first words and phrases are likely to be delayed in onset. Vocabulary size is smaller and less varied than expected. And ang sentences ay shorter and less complex with grammatical errors, especially sa past tense. So, deficits in comprehension of language are frequently underestimated as children may be good at using context to infer meaning. So, pwede rin magkaroon ng word-finding problems, impoverished verbal definitions, or poor understanding of synonyms, multiple meanings, or wordplay appropriate for age and culture. So, problems with remembering new words and sentences are manifested by difficulties following instructions of increasing length, difficulties rehearsing strings of verbal, and difficulties remembering novel sound sequences. So, a skill that may be important, so these skills are important for learning new words. So, difficulties with discourse are shown by a reduced ability to provide adequate information about the key events and to narrate a coherent story. For criterion B naman, language abilities are substantially and quantifiably below those expected for age, resulting in functional limitations in effective communication, social participation, academic achievement, or occupational performance, individually or in any combination. So, the language difficulty is manifested by abilities substantially and quantifiably below sa expected para sa age niya. At nag-interfere sa academic achievement, occupational performance, effective communication, or sa socialization. For criterion C naman, onset of symptoms is in the early developmental period. So, a diagnosis of language disorder is made based on the synthesis of the individual's history, direct clinical observation in different contexts, and scores from standardized tests of language ability that can be used to guide estimates of severity. For criterion D naman, the difficulties are not attributable to hearing or other sensory impairment, motor dysfunction, or another medical or neurological condition, and are not better explained by intellectual developmental disorder or by global developmental delay. Para naman sa associated features ng language disorders, so affected individuals, even children, may appear to be shy or reticent to talk, and mas piniprefer nila na mag-communicate only sa mga family members or sa mga other familiar individuals. Although these social indicators are not diagnostic of hindi siya diagnostic criteria ng language disorder, if they are notable and persistent, they warrant referral for a full language assessment. Para naman sa development and course, So language disorder diagnosed in children's ages 4 years and older is likely to be stable over time and typically persist into adulthood. Although the particular profile of language strengths and deficits is likely to change over the course of development. So language disorders can have social consequences across lifespan. So language acquisition changes from onset in toddlerhood to adult level. Ang individual differences naman is not highly predictive of later outcome. So for 4 years old, individual differences are more stable and highly predictive of later outcomes. Pag 4 years and older naman, stable over time and persists into adulthood. So social consequences of language disorder includes peer victimization, and females are 3 times the risk of sexual assault. Para naman sa risk and prognosis factors. So children with receptive language impairments have a poorer prognosis than those with predominantly expressive impairments. So receptive language impairments are more resistant to treatment, and difficulties with reading comprehension are frequently seen. For the environmental factor, bilingualism does not cause or worsen a language disorder, but children who are bilingual may demonstrate delays or differences in language development. So a language disorder in bilingual children will affect both languages. Therefore, assessment across both languages is important to consider. Para naman sa genetic and physiological, language disorders are highly heritable, and family members are more likely to have a history of language impairment. So, population-based twin studies consistently report substantial heritability for language disorder, and molecular studies nagasuggest sila na multiple genes interacting that the multiple genes interacts on causal pathways. For the differential diagnosis, normal variations in language distinction may be difficult to make before age of 4 years. Pero regional, social, and cultural ethnic variations of language must be considered when an individual is being assessed for language impairment. For hearing or other sensory impairment naman, hearing impairment needs to be excluded as the primary cause of language difficulties. Language deficits may be associated with a hearing impairment or other sensory deficit or a speech motor deficit. When language deficits are in excess of those usually associated with these problems, a diagnosis of language disorder may be made. Para naman sa intellectual developmental disorder, language impairment is often the presenting feature ng intellectual developmental disorder. And language disorder can occur with varying degrees of intellectual ability, and a discrepancy between verbal and non-verbal ability is not necessary para sa diagnosis ng language disorder. Para naman sa autism spectrum disorder, so, ASD frequently manifests with delayed language development. However, sa autism spectrum disorder, it is often accompanied by behaviors not present in language disorders, such as lack of social interest or unusual social interactions. Also, odd play patterns, unusual communication patterns, and rigid adherence to routines and repetitive behaviors. For neurological disorders naman, language disorder can be acquired in association with neurological disorders including epilepsy. And lastly, for language regression, loss of speech and language in a child at any age warrants thorough assessment. So language loss may be a symptom of seizures, and a diagnostic assessment is necessary para ma-exclude ang presence ng epilepsy. For the comorbidity, language disorder may be associated with other neurodevelopmental disorders in terms of specific learning disorder, intellectual developmental disorder, attention deficit hyperactivity disorder, autism spectrum disorder, and developmental coordination disorder. So it is also associated with social pragmatic communication disorder and may co-occur also with speech sound disorder. Next online, under the communication disorders, we have the speech sound disorder. For the criterion A, persistent difficulty with speech sound production that interferes with speech intelligibility or prevents verbal communication of messages. So speech sound production describes the clear articulation of the phonemes that in combinations make up spoken words. So these phonemes and these spoken words were discussed in our experimental research. Speech sound production requires both the phonological knowledge of speech sounds and the ability to coordinate the movements of the articulators, such as the jaw, the tongue, and the lips, with breathing and vocalizing for speech. For the criterion B, the disturbance causes limitations in effective communication that interfere with social participation, academic achievement, or occupational performance, individually or in any combination. So, children with speech production difficulties may experience difficulty with phonological knowledge of speech sounds or the ability to coordinate movements for speech in varying degrees. For the criterion C, onset of symptoms is in the early developmental period. So, speech sound disorder is diagnosed when speech sound production is not what would be expected based on the child's age and developmental stage. Among typically developing children at age 3 years, overall speech sound or speech should be intelligible, whereas at 2 years, only 50% may be understandable. Boys are more likely to have a speech sound disorder than girls. And for the criterion D, the difficulties are not attributable to congenital or acquired conditions such as cerebral palsy, cleft palate, deafness, or hearing loss, traumatic brain injury, or other medical or neurological conditions. So the diagnosis is made when the deficits are not the result of a physical, structural, neurological, or hearing impairment. Excuse me. For the associated features, so if the ability to rapidly coordinate the articulators is a particular aspect of difficulty, there may be a history of delay or incoordination in acquiring skills that also utilize the articulators and related facial musculature. Among others, these skills include chewing, maintaining mouth closure, and blowing the nose. So the term childhood apraxia of speech and verbal dyspraxia are used for speech production problems with motor components. For the development course, at age 3, children with speech sound disorder continue to use immature phonological simplification processes. At age 5, most speech sounds should be produced clearly and most words should be pronounced accurately according to age and community norms. So late 8 refers to the frequently misarticulated sounds in English also tend to be learned later, which are the l, r, s, z, th, ch, z, and z. At age 8, misarticulation of any of these sounds by itself could be considered within normal limits up to this age. So, lisping is particularly common and may involve frontal or lateral patterns of airstream direction. It may be associated with a tongue thrust swallowing pattern. For the differential diagnosis, normal variations in speech. Bilingual children may demonstrate an overall lower intelligibility rating, make more overall consonant and vowel errors, and produce more uncommon error patterns than monolingual English-speaking children when assessed only in English. So, for hearing or other sensory impairment, those who are deaf or hard of hearing may have speech sound production errors. When speech deficits are in excess of those usually associated with these problems, a diagnosis of speech sound disorder may be made. For the structural deficits, speech impairment may be due to structural deficits such as cleft palate. So dysarthria, neurological signs as well as distinctive features of voice differentiate this dysarthria from speech sound disorder. Although in young children or under the age of 3, differentiation may be difficult, particularly when there is no or minimal general body motor involvement. For
For the selective mutism, limited use of speech may be a sign of selective mutism, an anxiety disorder that is characterized by a lack of speech in one or more contexts of settings. So selective mutism may develop in children with a speech sound disorder because of embarrassment about their impairments. But many children with selective mutism exhibit normal speech in safe settings, such as at home or with close friends. For the comorbidity, speech may be differentially impaired in certain genetic conditions, such as in Down syndrome. If present, this should be also be coded.
Third online, under the communication disorders, we have the childhood onset fluency disorder or the stuttering for its diagnostic criteria. Criterion A. So disturbances in the normal fluency and time patterning of speech that are inappropriate for the individual's age and language skills. So it persists over time and are characterized by frequent and marked occurrences of one or more of the following. First, the sound and syllable repetitions. Second, sound prolongations or consonants as well as vowels. Third, the broken words or pauses within a word. Fourth, audible or silent blocking or filled or unfilled pauses in speech. Fifth, the circumlocutions or the word substitutions to avoid problematic words. Sixth, words produced with an excess of physical tension. And seventh, monosyllabic or whole word repetitions.
Criterion B, the disturbance causes anxiety about speaking or limitations in effective communication, social participation, or academic or occupational performance, individually or in any combination. So the disturbance in fluency may interfere with academic or occupational achievement and with social communication. The extent of the disturbance varies from situation to situation and often is more severe when there is special pressure to communicate. This fluency is often absent during oral reading, singing, or talking to inanimate objects or to pets. So for the criterion C, the onset of symptoms is in the early developmental period. So when later onset cases are diagnosed as F98.5, so these are called the adult onset fluency disorder. For the criterion D, the disturbance is not attributable to a speech motor or sensory deficit. The fluency associated with neurological insult or another medical condition and is not better explained by another mental disorder. For the associated features, it includes avoidance fluency, stress and anxiety, motor movements, language abilities. So relationship between fluency disorder and language abilities is unclear. Studies have shown both structural and functional neurological differences in children who stutter. Males are more likely to stutter than females, with estimates varying depending on the age and possible cause of stuttering. So causes of stuttering are multifactorial, including certain genetic and neurophysiological factors. For the development and course, so the disorder occurs by age of 80% to 90% of affected individuals with age at onset. Typically, yung disfluences is nag-start gradually pero hindi yun napapansin ng bata with repetition of initial consonants, first words or phrases or long words. As the disorder progresses, these fluences become more frequent and interfering. If nalalaman na ng child na meron siyang speech difficulty, he or she may develop mechanisms para ma-avoid yung disfluences and emotional responses. So for the risk and prognosis factors, we have genetic and physiological. So the risk of stuttering among first-degree biological relatives of individuals with childhood onset fluency disorder is more than 3 times the risk in the general population. To date, mutations of 4 genes that underlie some cases of stuttering have been identified. For the functional consequences, in addition to being features of the condition, stress and anxiety can exacerbate this fluency. Impairment of social functioning may result from this anxiety. So negative communication attitudes may be a functional consequence of stuttering, starting in the preschool years and increasing with age. For the differential diagnosis of sensory deficits, these fluencies of speech may be associated with a hearing impairment or other sensory deficit or a speech motor deficit. So when the speech disfluencies are in excess of those usually associated with these problems, a diagnosis of childhood onset fluency disorder may be made. For the normal speech disfluencies, the disorder must be distinguished from normal disfluencies that occur frequently in young children, which include whole word or phrase repetition, incomplete phrases, interjections, unfilled pauses, and parenthetical remarks. If these difficulties increase in frequency or complexity as the child grows older, a diagnosis of childhood onset fluency disorder may be appropriate. For the specific learning disorder with impairment in reading, children who have these fluencies when they read aloud may be diagnosed mistakenly as having a reading disorder. Oral reading fluency typically is measured by timed assessments. Slower reading rates may not accurately reflect the actual reading ability of children who stutter. Excuse me. Bilingualism. It is necessary to distinguish between these fluencies resulting from attempts to learn a new language and these fluencies that indicate a fluency disorder, which typically appear in both languages. For the medication side effects, stuttering may occur as a side effect of medication and may be detected by a temporal relationship with exposure to the medication. Adult onset disfluencies. If onset of disfluencies is during or after adolescence, it is an adult onset disfluency rather than a neurodevelopmental disorder. So, Tourette's disorder. Vocal tics and repetitive vocalizations of Tourette's disorder should be distinguishable from the repetitive sounds of childhood onset fluency disorder by their nature and timing. Comorbidity. Childhood onset fluency disorder can co-occur with other disorders such as attention deficit hyperactivity disorder, autism spectrum disorder, intellectual developmental disorder, language disorder, or specific learning disorder, seizures disorder, social anxiety disorder, speech sound disorder, and other neurodevelopmental disorders. Fourth online, we have the social pragmatic communication disorder. For the diagnostic criteria: A. Persistent difficulties in the social use of verbal and nonverbal communication as manifested by all of the following. First, deficits in using communication for social purposes, such as greeting and sharing information in a manner that is appropriate for the social context. Second, impairment of the ability to change communication to match context or the needs of the listener, such as speaking differently in a classroom than on a playground, talking differently to a child than to an adult, and avoiding use of overly formal language. Third, difficulties following rules for conversation and storytelling, such as taking turns in conversation, rephrasing when misunderstood, and knowing how to use verbal and nonverbal signals to regulate interaction. Fourth, difficulties understanding what is not explicitly stated and non-literal or ambiguous meanings of language. So for the criterion, A. Social pragmatic communication disorder is characterized by a primary difficulty with pragmatics as manifested by deficits in understanding and following social rules of both verbal and nonverbal communication in naturalistic contexts, changing language according to the needs of the listener or situation, and following rules for conversations and storytelling. For the criterion B, the deficits result in functional limitations in effective communication, social participation, social relationship, academic achievement, or occupational performance individually or in combination. So the deficits in social communication result in functional limitations. For the criterion C, the onset of the symptoms is in the early developmental period, but deficits may not become fully manifested until social communication demands exceeds limited capacities. For the criterion D, the symptoms are not attributable to another medical or neurological condition or to low abilities in the domains of word structure and grammar and are not better explained by autism spectrum disorder, intellectual developmental disorder, global developmental delay, or another mental disorder. So the deficits are not better explained by low abilities in the domains of structural, language, or cognitive ability or by autism spectrum disorder. For the associated features, language impairment is characterized by a history of delay in reaching language milestones and historical, if not current, structural language problems. Individuals with social communication deficits may avoid social interactions. Attention deficit hyperactivity disorder, emotional and behavioral problems, and specific learning disorders are also more common among affected individuals. For the developmental course, diagnosis is rare among children younger than 4 years. By age 4 or 5 years, most children should possess adequate speech and language abilities to permit identification of specific deficits in social communication. Some children may improve and others have continuing difficulties until adulthood. Early deficits in pragmatics may cause lasting impairments. For the risk and prognosis factors, genetic and physiological. So, a family history of autism spectrum disorder, communication disorder, or specific learning disorder appears to increase the risk for social pragmatic communication disorder. This includes siblings of children with these disorders who may present with early symptoms of social pragmatic communication disorder. For the differential diagnosis, for the autism spectrum disorder. The two disorders can be differentiated by the presence in autism spectrum disorder of restrictive repetitive patterns of behavior, interests, or activities and their absence in social pragmatic communication disorder. Yung diagnosis naman ng social pragmatic communication disorder should be considered if the current symptoms or developmental history fails to reveal evidence of symptoms that meet the diagnostic criteria for restricted repetitive patterns of behavior, interests, or activities of autism spectrum disorder causing current impairment. For the attention deficit hyperactivity disorder, primary deficits of ADHD may cause impairments in social communication and functional limitations of effective communication, social participation, or academic achievement. For the social anxiety disorder, the symptoms of social pragmatic communication disorder overlap with those of social anxiety disorder. The differentiating feature is the timing of the onset of the symptoms. In social pragmatic communication disorder, the individual has never had effective symptoms. In social pragmatic communication disorder, the individual has never had effective social communication. In social anxiety disorder naman, the social communication skills develop appropriately but are not utilized because of anxiety, fear or distress about social interactions. For the intellectual developmental disorder and global developmental delay, social communication skills may be deficient among individuals with global developmental delay or intellectual developmental disorder. But a separate diagnosis is not given unless the social communication deficits are clearly in excess of the intellectual limitations.
For the childhood onset fluency disorder, researchers show that rather than anxiety causing childhood onset fluency disorder, this problem makes people socially anxious. So multiple brain pathways appear to be involved also, and genetic influences also can be a factor. Para naman sa treatment, parents are counseled about how to talk to their children. So we have this regulated breathing method. It is a promising behavioral treatment in which the person is instructed to stop speaking when a stuttering episode occurs and then to take a deep breath, exhale, then inhale before proceeding. So altered auditory feedback or the electronically changing speech feedback to people who stutter can improve speech, as can using forms of self-monitoring in which people modify their own speech for the words they stutter. For the language disorder naman, for the etiology, an unfounded psychological explanation is that children's parents may not speak to them enough. A biological theory is that middle ear infection is a contributory cause. Para naman sa treatment, may be self-correcting and may not require special intervention. Para naman sa social pragmatic communication disorder, for its etiology, merong limited information. Para naman sa treatment, individualized social skills training such as modeling or role-playing with an emphasis on teaching important rules necessary for carrying on conversations with others, such as what is too much and what is too little information, can be a treatment.
For the unspecified communication disorder naman, or F8.9, this category applies to presentations in which symptoms characteristic of communication disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria for communication disorder, or for any of the disorders in the neurodevelopmental disorder diagnostic class. The unspecified communication disorder category is used in situations in which the clinician chooses not to specify the reason that the criteria are not met for communication disorder or for a specific neurodevelopmental disorder, and includes presentations in which there is insufficient information to make a more specific diagnosis.